There are other things that.
All right, are we ready for our next part of fun? Yes, you say. Okay. We hope you've had a chance to get to introduce yourself at the tables. There's a method to the madness of reorganizing us. You get to meet other people. And I wanted to just remind ourselves, right? Sometimes I get into a certain mode of thinking, but we have patients here. We have people here who are funders and are bringing a population perspective. We have those that are coming from a more public health hospital system, private university. And there you are, our Cigna representative. We have many stakeholder perspectives, right? And I just want to reiterate what you said so well is that our openness and really seeking to understand and listen that every stakeholder's perspective is important. And what brings us here together is because we care about patient health. And I know there are a few patients who are here and they're maybe wondering, like, gosh, is this what they do when they have these meetings? But we will report out tomorrow on this, and your voices are very important because it forces us to be able to talk and communicate in ways that are relevant for patients and you. And we have to learn from your voice because you're the wisdom that guides how we think about care, because we're all patients too, right? At some point in our life. Okay, so this next hour or so is starting to get us to think about the wisdom of the crowd as it relates to implementation. We have an implementation kind of framework that will get us thinking about that. And then we'll have small group discussion and then a report out. We'll have in a second description of what this is. But importantly, just so you know, this is what we're going to ask you to think and reflect about. There are these different sections here that are common areas you have to strategize about when you think about implementing something and how ready are you, etc. So we'll be getting you to discuss, recognizing everyone at your table might be at a different place of implementation. So a chance to learn from one another what's challenging and what have been local strengths that have been catalysts. So at many of your tables, we have embedded someone that is an implementation scientist from the ITM in Loyola. And I'm wondering if you all can raise your hands, just so you know you have some resident experts here. So we have Naomi Mora, we have Maddie Niho, we have Teresa Burkhardt, and we have Fran Weaver. And they will be at your tables, the ones that will help report out. So your job is to listen for themes on this. Let's see, other tables, do you want us to just have the report out person? Yeah, we'll go to the other tables so that you don't have to have the burden of the reporting out, you have the burden of the discussion, okay? So this session will be maybe about 15, 20 minutes of discussion, and then we'll ask everyone to report out, okay? So first, you need to understand what is it we're actually looking at. So I'll turn it over. Emily.
Yeah. Okay. Go back to this. So just some background on what this table, and we call this a spider diagram, is. We're hoping that this is a framework to think about implementation, whether it's the first start of implementing, another step of care continuity or integrating social services into an already existing, CCP or CCP-like program. It should represent thinking along the spectrum. But we developed it originally as a way to assess if there was a new site that was interested in implementing a program like CCP, could we sort of collaboratively talk about the key domains that we believe, and we've tested this out a couple of times as a tool, are critical to the implementation and sustainability of implementing a CCP or similar model. So you can see the domains here: patient population, hospital, clinic, human resources, meaning not HR in the typical sense, but the humans that are making up the team, providing the services, stakeholder buy-in, many of the stakeholders that we've talked about, social needs and finances. And so in the description, you see sort of higher level questions that give you a sense of how to reflect on that domain. This is associated with a sort of longer list of questions that then are weighted differently, and you can see that in sort of the smaller pie charts around the center diagram that, you know, if we were fully doing this, we'd be able to get a sense of, are you in the green? You're definitely serving the patient population that is a good fit for a model like this, but you don't have any physicians who are willing to participate, so you'd be in the red for that. So using this as a tool to reflect, the worksheet in front of everybody is hopefully a way that, and you might be wondering why there are crayons on your table and it's for this purpose. Reflecting at a high level, and at the end of everybody's conference booklets, you'll have the same table here if it's easier to look at the questions. We'll go to the next discussion questions in a second. If it's useful to, you know, visually represent where you feel you are and you might have barriers, feel free to sort of follow along intuitively how you feel, green, yellow, red, shades of red in the diagram. It's also possible that, you know, you don't want to work visually like that, and so feel free to just use the questions to reflect. So let me. So these are the discussion questions. I think we want to spend about 5 or 6 minutes just individually thinking about where you are in implementing and where barriers might be or have been, and using that diagram and the questions to guide that reflection, and then sharing together and having discussion.
Yeah, so you can turn to the back page of your booklet if you haven't already. We'll give you 5 minutes to just do that personal reflection, take some notes. It could be you have a lot of detail. It could be it just triggers a lot of questions for you, and that's okay. Then we'll turn over to table discussion, and then the report out will be around these questions, and we'll gather like some general learning. So 5 minutes. To 25 after, we'll let you go.
All right. Bring our attention back.
That builds in more administrative time.
I think it's just been fascinating how the conversation happening on the tables. I mean, that means you're all really into implementation science and talking these topics. Sometimes people, and I'm just so amazed, people are using the crayons and filling it in, you know. They're there to, what is a lot of implementation science? It's structured frameworks so that you are systematically prompting yourself to think about key things in a way that's structured and it's based on, behavioral change theory. And so these are tools, right? And they can be used to evaluate, they can be used to plan. And that's why we brought them here. It's also a way to learn, because every site will have a slightly different color diagram and maybe choosing different strategies. So this is the part now where we learn from each other. We're going to do a lightning round of learning, maybe about 3 minutes per table, something like that. And we're going to start with table 1. Oh, and we're capturing key ideas up here so we don't lose them.
Well, we didn't really follow the rules, but we had a great conversation. First we heard from Krista about Ingalls, which has a small CCP program. And even though it's been successful, there's still resistance from the leaders. And it's really because they don't see the value. And so maybe it's a small little program. They don't bother anybody else too much and it's okay, but probably couldn't get expanded without leadership buy-in. So, and then we talked about how the CC program that, from a researcher perspective, how much patients really love their doctors when they have that relationship. And when that gets out of kilter, like they go to the ER and they see whoever the doctor is there, that there's like issue of trust. Some of these patients have actually said, that's it, I'm not doing this anymore. You broke my trust because you weren't in the ER for me. And even though there have been attempts, I think at Rush and other places to have a system where the ER doc can call the PCP, that's probably not very realistic a lot of times in ER. But nonetheless, an issue that could cause problems. And then we started talking more about communication issues and how the CCP program might be strengthened by being a PCP social worker team approach that addresses a lot of the social issues. That the social worker could delve into some of the social concerns that might be the underlying cause of some of the medical issues that are being seen by the doctors. And that together, the PCP and the social worker could both develop that trust with the patient, but also address the healthcare and the social related issues. We talked about Kaiser and the importance of patient trust, that it's a real strength, and that they have had some success with virtual touches. And there's a lot of plus and minuses about whether integrating telehealth into this kind of a program is a good thing or not a good thing, or maybe you can do some of both. Another interesting thing that came up was space. So if you have one of these programs, can you get the space for your program? And I think we're all in situations where space is at a premium, and this is not your cardiac surgery group that is bringing in, all the money. And so you're not at the top of the list for asking for space. And so you have team members that may be, down the hall or might be in another building. It makes it a lot harder to manage these complex patients' concerns. Let's see, what else do we talk about? Just the importance of hospital leaders and payers, really having them on board. It's so much more difficult if they're not on board. And the most difficult thing about that is they showing them what the value is. They think dollars, but there's so much more. And they often don't see that. Group, what else?
Yay, great fun. So we're capturing a couple of things. How we think of who's on the integrated team. I'm hearing from you is maybe the ER doctor, the social worker, how we define care coordination and who's on the coordination team more directly. And so I'm curious if others, as you go around, if you have the solution for answering the senior leadership and hospital leader, what's showed the value. That may be a consistent theme. And I think space is excellent because if it's all about integration, co-location is really important. And when you're not what is it, the data shows that for every 6 feet you're away in your office, there's like this huge decay curve on your likelihood of working together. It's huge. I mean, it's pretty rampant. So thank you very much.
Table 2.
Hey, table 2. We had a selection of programs here, but a couple from University of Chicago with the full model. University of Wisconsin has the inpatient side. FQHC, Lonsdale Christian is considering. And then we have the French model that it's going to come someday. So a lot of similar issues. I kind of broke them up into like an administrative bucket. So the space came up again. So how do you justify this space and you're not using it all the time? For U of C, that's kind of a continuing saga with administration. With Wisconsin, you don't have the clinic, so you avoided that. You just have the inpatient side. But an interesting topic came up when they were talking about rolling this out. There was a concern that all these intense inpatients would be in one unit. And so you brought up how the nursing, revolted or whatever. I'm phrasing that.
They revolted.
So lesson learned, like the communication with the state.
I met the CEO very quickly.
It went up matter very quickly. So the word got out that they were intensive patients, but then that way it was going to be rolled out, needed to have the stakeholder buy-in. And then the other administrative aspect is just the money side of this. Does it make money? Are the patients gaming the system? That kind of came up and things like that. So, really being able to document the value of the program. Then talking about the recruitment of staff. So the physicians in the program have to have the comfort level on the inpatient and the outpatient side. And so just like, how does that work in reality? Like some naturally migrate to one or the other, but there was a theme that the patients really don't mind if it's kind of a different person each time, as long as they know that those doctors are talking to each other and kind of see them as a person. Yeah, but then several of the physicians brought up just like some physicians choose this, like they want that relationship and they want that personal relationship. So like in the recruitment and a lot come out of grad, after they grad, they get into this and continue the inpatient and outpatient skills. Let's see, what else did I miss? Oh, some discussion about like being able to tell the stories too about the value that it brings, the patients that are affected, and that will help with communicating the stakeholders and to the leadership.
So a real theme of who is on the care coordination team. Now we're adding nurses. It needs to be part of the integrated upfront conceptual framing. I'm also hearing, and maybe this will come up tomorrow, David, when you talk about workforce, the type of physicians who might select into an inpatient outpatient role. I would imagine there's a lot of selection bias going on in med school that you're choosing either ors, right? There's not a specialization in this. And so you're also kind of bucking the natural flow of here's how medical education is being delivered. So that might have areas of interest in specialized fellowships or things like that to cross that. Okay, they both, and I also appreciate Teresa has a master's in healthcare administration. So it's good to have people who have an administrator hat on because they are also your ally in being that empathetic listener to what those leaders are keeping up at night. Okay, Naomi.
Table 3. Okay, so we have also representing 3 different models and different adoption stages, very early stages. We start like the pioneers, and then we have a later adopter here. So they have different problems, of course, but one common theme is resources. As we hear it, space is one, and the other one is staff, and not necessarily medical staff, because primarily the leadership buy-ins that they need doctors, but not necessarily social workers or community healthcare workers. So that's part of the model that is being identified in all of the teams as necessary for success. One strategy from Chicago is that getting these business reports monthly to the leadership to demonstrate that there's return of investment and where they can invest further. So I think that was something new. Going back to this. Communication. So when the teams are not based in the same place, it's more difficult. That's primarily Rush's case, is that they need to communicate that to the model, the physicians in the model, that the patient is there and that there's lost that time and it's fragmented the current. That's one problem here. It says space, buy-in, the education and medical schools, right? So the recruitment of physicians is that the people don't know if they should choose to hospitalize or outpatient, but from education standpoint, I identify that we need to educate better everybody about this type of care. The same way to leaders, right? The healthcare administrators, that this is something and they can actually have wins in these models. And they have addressed that through steering committees as well. Let's see. Am I missing anything? No?
Yeah. I hear space has now been mentioned in all three tables. Table 5, is space on your list? It's probably because the spaces of health systems have been built because of the siloed aspect of the specialization. And so that's as much a part of the care coordination as like, that space. It's interesting. The business reporting is, that may be an area for the team to think about. How do you templatize that? Or how do you create it as like a dashboard that can be used in other places so every site's not trying to reinvent the wheel? And how do we get that kind of data from your system for reporting? So that might be something that's a transferable insight. Okay, Maddie, table 5.
Thank you. Hi, everyone. So we had representatives from U of C, CCP at our table, Cigna, and Cook County Health, so a good mix. Some strategies that we talked about to address barriers are the buy-in that people already mentioned, so the importance of having physician as well as union buy-in, partnering with Medicare Advantage, creating incentives for providers, and kind of looking at this like beyond the 5 Ps that are up there. And also looking at how power dynamics within the health system defines a lot of these frameworks. And how the payer would also rather have a longer length of stay. That kind of came up versus like from the provider side.
So can you share more on that, both on the power dynamics? Give us a little bit more insight, maybe on that.
Yeah, do any of my friends at my table want to?
I could just quickly just share.
And also, why would the insurer want longer length of stay?
So from a Medicare Advantage perspective, right? So from the power dynamics, I could say that, coming again from an academic side, the people in the table are very different and what they're looking for is very different than when they go for a for-profit side. And then, so basically you have to kind of know what their map is of how they understand things. So that's what I had to change when I moved to this for-profit and learning, okay, this is what's happening here. So that's the key thing, because every health system, it's kind of interesting how there are some more predominant groups than others, and either historically they've been like very strong, whatever that is, but kind of understanding that nuance per health system or organization that you're in.
And so longer length of stay is a benefit because?
So the insurance just pays for Medicare Advantage a certain amount, right? So whether they stay 10 days or 3 days from a insurance, it doesn't matter for them, right?
So there's no incentive.
There's no incentive,
But it's a huge disadvantage for the hospital.
It's a huge disadvantage for the hospital,
So it's
but
conflicting interest.
Huge disadvantage to have them in there a long time.
Because they're using more
Yeah,
and more.
yes, the bed's full. Yeah. Anything else, Maddie?
And we just also talked about the importance of how everything is kind of translated into financial metrics. So for example, like how does the Artful Living program, how is that linked to decreasing length of stay? So kind of talking through that some more. Yeah, just working to really bridge payer and provider relationships came up a lot as well.
Yeah.
Anything else?
Excellent. Thank you. All right. And we'll let David close it with table 4.
Great. Okay. So I'm gonna first start by saying we also talked about space. I also want to provide a little methodological insight to the flawed analysis here, which is that there are U of C people at every one of these tables, and that's probably why space was mentioned again. So as much as I think it's important, I just wanted everyone to know. We spent most of our time talking about the team. And the team being not just the doctors, but the case managers, care coordinators, nurses, social workers, everyone. And a lot of the focus was around sort of how many people you need and how you know when you've got the people you need. And one of the first things we realized was that the number of patients per sort of care coordination person varied by approximately 20-fold between our programs. From 500 to 1,000 people per patient to as little as perhaps even 25. And we talked about sort of why that was. And, there was some openness to the idea that there could be complexity or acuity or other things. But there was a lot of sense that some of it just couldn't be explained by need, but had to be explained by other things such as, internal power dynamics and history and other sorts of things. We had brief moments where we tried to be scientific about it and think about, should we do time motion studies? Should we document this stuff? But those were brief. I think we also talked a little bit about, organizational dynamics and the role of innovators and the roles of research within this. I think, this is partially me commenting on self-reflection. I think one of the challenges of being an innovator and bringing something to a place is that you are almost too committed to it. And then the question is, when you're committed and the hospital is going for the squeaky wheel, who do they respond to, right? And if they know you will tolerate a certain amount of stuff, they continue to allow that amount of stuff to happen. And so I think that's a really interesting translational science problem about how we bring innovation into systems. And I have my own biases about it, but I think it's a serious problem that needs to be discussed. So I think, we mainly talked about Rush and U of C, but within U of C, we talked about the care coordination programs, we talked about CCP. The last thing I do want to say, because I don't think I mentioned it earlier and I meant to, was that, one of the things about CCP is it does require less care coordination because there's less fragmentation. And we had a really nice conversation about the extent to which the work of care coordinators in dealing with a fragmented system is that much harder because it is fragmented. So when I say, it varies by 20-to-1, ratio, I do think we should be aware that one of the advantages we can offer in programs like this is less need. I don't think we can reduce it 95%, but, some percent less. Stop there.
Do you mean less need of, you don't need as many health professionals?
You don't need as many, like if someone's job is communicating between the inpatient and outpatient doctor, we don't need that person because I can talk to myself.
Okay.
So this, just to be aware, I'll give you a counter argument. Does that mean those people lose their jobs?
Oh, no, they can take care of other people.
All right, no, but I mean the ones communicating. Are you talking about like physicians communicating or staff, front staff?
I'm saying that there is plenty of care coordination work to go all around, lots of value. They just don't need to be spending their time putting together these pieces.
Okay. So it's they can be at the top of their license in the care that they're providing. Rather than
Actually, Chris, I'm glad you raised your hand because can I just say one thing and then you'll say it. One of the most memorable meetings in all the years I've been working on CCP is the first time I went to Ingalls. And Ingalls at that point had a much better care coordination program than U of C. This was 8 or 10 years ago, maybe more. And I was worried that the care coordinators would say, this is a terrible idea, we're going to lose our jobs. And they said exactly the opposite. They said, we love this because we can then do the really high value stuff we do rather than chasing back and forth between you doctors.
Yeah, and I was gonna say then, this just means you don't have to hire more
Right.
people, because to actually get a job done. Where right now, they're not getting the job done, and I'm hearing that they're like spinning their wheels, trying to hurry up, and they can only do so much. In this way, they don't have to do more, they can actually coordinate things more efficiently.
Right.
But you're not eliminating.
That's the value proposition words we're trying to extract out. You don't have to spin your wheels. You can be doing the job that you've trained for, not the other piece. So that's exactly pulling out like what's the value of this. It's the then you have to think, all right, how am I going to measure that? Demonstrate that, etc. So this was the section thinking about implementation strategies. We hope that it kind of sparked some conversation. We'll pull out themes. I know in summary here, the next two sections are designed to now think about what is the core intervention that we're talking about, both in terms of care coordination, what's the core elements and what are the adaptable elements? What are the core things on the social service support? What's the adaptable one given the context? So they're going to be lightning rounds. They'll be moderated by CCP folks.
but I want you to be listening through a lens of implementation science. Right? So in that lens, what is core and what are they adapting? And why are they doing it? Right? Why, just listen, and if they're not saying it, I'm sure the moderated discussion will pull it out. That, we talk in implementation science, context matters, and you'll see this in what Fran presents tomorrow in the evaluation framework. Context really matters, and we need to be listening through this so that we say, okay, in that context, they went this way. What might be my context or another context? How generalizable is this context? That's how implementation scientists think. But right now we're taking 15 minutes for a break. So we'll reconvene at 2:30. Thank you.